Hi everyone, my name is Kara Neese. I'm the PGY2 Infectious Disease Pharmacy resident at Duke University Medical Center, and today I'll be presenting on antimicrobial stewardship for UTIs in 3 emergency departments. My co-investigators and I have nothing to disclose regarding this project and presentation. Over 47 million unnecessary antibiotics are prescribed in the outpatient setting and EDs each year. Annually in the U.S., it's been estimated that approximately 3 million ED visits are for UTIs. UTIs are often misdiagnosed and lead to unnecessary antibiotic use, which increases the risk for adverse reactions, Clostridium difficile infections, and antibiotic resistance. The purpose of this study was to quantify the impact of a 2-phase educational antimicrobial stewardship intervention and data feedback on the rate of institutional guideline-directed prescribing for UTIs in the ED. This was a prospective 2-phase experimental study conducted at 3 ED locations. Baseline data was collected 1 year prior to the first phase. Each phase consisted of an education and data feedback intervention. We'll go into more specifics on the next slide. We collected data prospectively during phase 1, which is about 5.5 months, and phase 2, which was about 6 months. During each phase, we used data we were collecting to provide data feedback. This table describes our interventions in more detail. We first developed an ED-specific urine source antibiogram, and using that data, we developed a UTI diagnosis and treatment guideline. Phase 1 and Phase 2 both included educational sessions regarding the antibiogram and guideline. For Phase 1, we provided a 1-hour in-person session at each ED, a recorded education session, and resources were posted in the ED and sent via email. For Phase 2, we provided a very similar education scheme. However, instead of giving in-person sessions to large groups, we provided more one-on-one and small group sessions due to COVID. Phase 1 and Phase 2 both included data feedback. For Phase 1, department-level data was sent to the ED departments, and for Phase 2, we sent out that same department-level data and additional provider-specific data. Provider-specific data was sent to the top and bottom 3 providers based on the rates of guideline concordance. Subjects were identified via Deduce, which is a web-based research and QI tool based on age, location, and ICD-9 and 10 codes. Inclusion criteria included adults diagnosed with cystitis or pyelonephritis at one of the 3 Duke EDs. Patients were excluded if they were subsequently admitted to the hospital. The primary outcome was rate of guideline-directed antibiotic prescriptions for UTIs based on the ED-specific guidelines. Secondary outcomes included the rate of UTI diagnoses, median duration of therapy, treatment failure, and adverse drug events. The latter 3 are based on a random sample of 2% of the population. Due to time limitations, I'll only be discussing the primary outcome. We used an interrupted time series analysis to assess the rate of guideline concordance and UTI diagnoses over time. This figure displays part of our ED-specific UTI algorithm focusing on the diagnosis assessment. We suggest that urinalysis criteria plus symptoms should be present for diagnosis and treatment, with a list of specific circumstances when asymptomatic bacteria may be appropriate to treat. The algorithm also includes information on how to classify UTIs as uncomplicated or complicated, which impacts our duration recommendations. This figure illustrates the second half of our ED-specific UTI algorithm. The treatment section is broken down by UTI classification and includes tiered recommendations based on our ED-specific antibiogram. For cystitis, we recommend nitrofurantoin or ceftriaxone as first and second-line therapy, respectively. For pyelonephritis, we recommend ceftriaxone or gentamicin times 1 dose, followed by trimethoprim, sulfamethoxazole, or ciprofloxacin as first line, or beta-lactams as second line. Transitioning to our results, during all phases, including the pre-intervention phase, we included 10,426 patient encounters. The median age was 44, 76% of patients were female, 54% were Black, and 54% were non-Hispanic. We also assessed insurance and coverage. 45% had private insurance, 33% had Medicare, and 21% had Medicaid. The distribution of demographic characteristics were similar in all 3 phases. Here's a visual of the rate of guideline-directed antibiotics at the academic ED. The y-axis represents the percentage of guideline-directed antibiotics, and the x-axis represents each 2-week period relative to the first education date. The red dashed lines demonstrate when each education occurred, and the blue dots on the x-axis show an estimate of when data feedback was sent out. These two graphs demonstrate data from each of the 2 community hospital EDs. The y-axis and the x-axis are the same as the previous graph I described. Visually, you can see an increase in slope during phase 2 at both EDs and a gradual trend towards higher rates of guideline-directed antibiotics over time. Looking at the results of our primary outcome, which again was the rate of guideline-directed antibiotics, we saw a 15% increase in the rate of guideline-directed antibiotics in phase 1 compared to phase 0. There was also a significant change in the rate of guideline-directed antibiotics over time during phase 2. With every 2-week period, on average, there was a 3% increase of concordant prescriptions. The average rate of guideline-directed antibiotics for the community hospital number 2 was 35% lower compared to the academic hospital, and there was a significant difference in rates comparing the 2 community EDs. There was a significant initial increase in guideline-directed prescribing in the ED in phase 1 compared to the pre-intervention period. We also saw a significant increase in guideline concordance during phase 2, but not during phase 1. It's possible that we saw this increase due to the implementation of provider-specific feedback during phase 2. This study does have its limitations. We were unable to ensure education was seen by all ED providers, we were not able to confirm emails were received, and our diagnoses relied upon ICD coding. In conclusion, education with diagnosis and treatment algorithms and ED-specific antibiograms were overall well received. Monthly provider-specific feedback on guideline concordance may have increased practice changes. Overall, our multifaceted stewardship intervention was effective in increasing guideline concordant antibiotic choices in the ED. I would like to acknowledge my project advisors, co-investigators, and statisticians. Here's my self-assessment question. Thank you, and please feel free to email me with any questions.